Thank you to both speakers. It really is a terrific, interesting case. I have a few questions, but I think I'll open it up to the audience first. Are there any questions? Let me just ask either of you, I was thinking as you were talking about HRD and platinum, are there any retrospective data looking at response rates in the old trials or even case series based on HRD, looking back at paraffin blocks or fresh tumors? In other words, are the good platinum responders in biliary tract cancers, are they HRD patients in retrospect that we didn't know about 10, 15 years ago?
I don't think that exists. I don't know if, John, you have any data about your ABC study in HRD, but you know, that has not, frankly, been published to my knowledge.
I mean, I would expect it from the pancreas literature.
So from the pancreas literature, it's there is actually a study by Milland, I think Milland's group, that looked at pancreas with olaparib, both HRD and BRCA, and actually the HRD patients, there were a couple of patients. It was an Israel cohort and an MD Anderson cohort, and I think the cohort from Israel had 2 responders, non-BRCA.
I think that's
HRD.
the paper you're referring to even.
No, that's a
the
different
germline cases. That's Talia Galan's paper, right?
Was it pancreas?
Okay, let me, those are biliary. Yeah.
No, there was a pancreas one. It was presented, it wasn't published. It was presented. So there were 2 cases in pancreas. So I suspect there will be some baseline responders. I don't suspect it's going to be at the level, at least, you know, from looking at the combined literature, it'll be at the level of the true BRCA, PALB, and maybe even FANCD.
There, first in line there.
Thanks very much. Your patient, if he unfortunately relapses with inoperable disease, what are you going to treat him with? Platinum-based therapy, PARP inhibition, both?
That's a good question. My understanding is those are both potential options. Dr. Kelly, I don't know if you have any sort of first-line option in mind. I presume we would cross that bridge if and when we come to it.
Probably would start with a platinum-based combination, or again, it'll depend on the pattern and time course. But the delayed recurrence is unusual. Oh, thank you. He's had such a delayed pattern of recurrence. You know, certainly we would reconsider the unorthodox approach of local ablation like we did to that single liver lesion, again, if it were so delayed in time and space. But if he had the need for systemic therapy, certainly a platinum-based regimen such as GemCis or potentially a PARP combination if in trial or depending what the time course is of approvals.
I think the lineage aspect is fascinating, showing that they're all the same tumor. We've seen similar findings in a bunch of pancreas cases and about lineage tracing, and they seem to have a better natural history. It's a different pattern of disease for reasons that aren't really clear, but I think your case is so interesting because of the metachronous, or the proof that it's all the same tumor and they're not different tumors. Something for people to think about when they see these cases. Yes?
Really interesting talk. So I was wondering, you know, with a lot of patients being heavily pretreated, is there any data, particularly with the PARP trapping inhibitors, the newer generation discussed, are these going to be more effective, less effective, or does that prior exposure to chemotherapy regimens have any bearing? Should they be used earlier line? Or?
Well, that's a great question. The traditional wisdom was essentially that if you fail a platinum, you're not going to do well with a PARP inhibitor, which makes kind of sense because ultimately they share very similar pathways. The reality is, if unexposed to platinums, it doesn't matter where you put them along the line of therapy, as long as the patient is able to get treatment, you will get a response because they're quite sensitive regardless of what stage. So preferably, and that's what, you know, a lot of the studies are trying to do, is to move them up the line ultimately, either in maintenance, sequence, or in combination. I mean, that's probably where you want to place them best. On their own, they have a very low response rate. I mean, the responses are great when you get them, but 10-20% is not satisfactory. It's a good start. And I think, again, the problem is because you're hitting only one pathway, and I suspect, again, rational combinations with topoisomerase inhibitors or other DDR inhibitors in immune therapy will start bringing those up the line and increase the response rate by combo.
Yes. Oh, 2 microphones?
Thank you.
I don't see that one.
The study of 18 BRCA patients with cholangio, there's a greater number than that, isn't there? And could Foundation One confirm that, just as they did with that unique patient?
There likely is a greater number, but again, at least to me, one of the striking things about this retrospective study across 5 institutions in multiple countries was that there were only 18 cases reported. I don't know if there's any additional data from Foundation or if you have any additional information, Katie, on whether the cohort has accrued additional patients since then.
No, so this was an institutional study. So it wasn't just Foundation Medicine data for the 18.
Right.
Actually, we were part of that study. This is, what we found in our databases. The percent of direct link is probably no more than 1 to 2% for the germline. And somatic maybe add another 1 to 2%. So BRCA on its own is a very low yield target, like pancreas on its own. When you start looking at, the additional alterations, the HRD, so you start expanding, this is where in biliary cancer you get up to 20 to 30% with some element of genomic instability and the DDR deficiency. And that's really the group of patients you want to expand to. I mean, we know that these specific BRCA are rare, but they do tend to respond really well to platinums. They also respond relatively well to PARP, but that's only a very small fraction. What we want is bring that pie to the 20 to 30% and find ways to essentially take advantage of these alterations and maximize essentially the damage to, like I said, maximize damage, prevent repair, make sure that, we have a dual or triple targeted strategy in sequence or together, to maximize the opportunities there.
And would they respond equally well if they're germline or somatic?
So to single PARP inhibition, the answer is no. You expect I would expect, and that's probably speculation prospectively, to have about a 20% response rate for single PARP inhibition with true BRCA. Whether somatic or germline doesn't matter. I mean, we know that from pancreas as well. On the other hand, for the BRCA-NES, what we know in pancreas is, or those HRD, at least from pancreas, we know that these have a much lower response yield, about 5%. There's a number of patients who have stable disease prolonged, but these are not paramount to responses. And so that's again why PARP inhibition on its own is probably not the answer or the only answer, and we really need to think about expanding beyond just PARP inhibition.
Could I just make one quick announcement? And we'll continue the discussion, Greg, sorry. We are starting the industry forum in 151A, B, and C. So if you are an investigator who has signed up and will be in that meeting, lunch will be served down in that meeting, and we need you to head out for that meeting. Also, the EPIC session is beginning for the patients who signed up for that in 151G, and lunch will be served there in that room. Lunch for everyone else will be here, but we'll continue the discussion. This is a great discussion.
Yes, sir.
So, Tony, that's a nice talk. There's a large number of patients with mutations in the epigenetic modifiers, ARID, particularly. How do you think about targeting those?
Oh, absolutely. I mean, so the effects are probably not just genetic, but there's certainly. I mean, that's primarily, of course, it's still at the preclinical level, at the early development level. That the epigenetic alterations may be another driver, of course, and certainly adds a level of complexity, or may essentially expand the pool of those patients we may be able to target. So I think, especially when thinking about combinations with immune therapy. This is where actually you may end up getting your biggest bang for your buck.
Thank you.
I think one of the limitations of the data on germline is that case series
Yeah.
is really just a biased case series of collections in various hospitals, but the population-based series haven't really been done. But I think the pan-cancer TCGA paper, the germline paper, and then
Yeah.
the upcoming ICGC paper may give better estimates. We were surprised in pancreas, it's as high as 5%. I don't think it's that high in biliary tract cancer, but I don't think we actually know.
Yeah, the problem is, again, it's the germline versus the somatic. And so in pancreas, if you add the germline and the somatic, then you're starting to, you start inching up.
Yeah. Next over there.
I was just wondering if there's any thought to using PARP inhibitors as adjuvant therapy in patients with germline ATM, BRCA mutations. And just a second question, if anecdotally, since there's 4 or 5 PARP inhibitors out there, if any of them have shown a little bit better effectiveness in patients with cholangio?
So the answer has to come from a lot of different sources, because in cholangio, there are very few patients that have been, reported on with PARP inhibitors. Veliparib is the only one, I think, that has no activity. All others have very similar activity. They're all in the same range. They all have very similar catalytic as well as trapping activity. So they end up being in the same ballpark of responses when you look across multiple malignancies. I think talazoparib is a little bit more potent in terms of its trapping, I believe. But when you look at their expanded study that included essentially a bunch of cancers, the response rate remains very stable around the same. So I don't think there's an advantage for one versus the other. Regarding the adjuvant piece, I think it's a great place to actually look at those PARP inhibitors. There's a study right now in pancreas that is about to complete, or completed, will be reported on hopefully soon. That's the POLO trial that looked at FOLFIRINOX for, I think, 4 months, and then those that responded or had stable disease would go on maintenance PARP. That would establish a good proof of concept about the role of PARP inhibitors in controlled disease or minimal residuals, and may move those to the adjuvant. There were some concepts trying to move through the NCI cooperative groups with adjuvant concepts with PARP inhibitors. They essentially were put on a stall pending what we see with the POLO trial. But that's the next probably level of looking at those, specifically as maintenance following chemotherapy.
Yes, over here.
Would you comment on the potential of oncolytic viruses as a delivery mechanism for PARP inhibitors?
So combined with PARP inhibitors?
Delivery.
Yes.
So oncolytic viruses, are certainly...
As a combination.
Sure. No, I understood. So the oncolytic viruses, it's a very interesting field. It's a fascinating field. The concept of essentially oncolytic virotherapy continues to evolve. We know in melanoma we have a little nice proof of concept that hasn't been duplicated quite significantly across the board, but there are signals that in hepatobiliary cancer specifically that you certainly could modulate that milieu. Now, whether PARP inhibitors through inducing DNA damage and modulating that immune milieu would be good to combine with these oncolytic viruses certainly makes sense. But I don't think there's anything right now that's looking at that. I mean, understanding how DNA damage and PARP inhibitors may work with their immune milieu could make this a very attractive proposition.
Actually, Tony, I wanted to follow up on that because the HRD pancreas cases, keep talking about them, have this immune activated signature.
Yes.
And I think it's been mentioned, I saw it mentioned this morning at ICRN, and maybe you mentioned it, but can you just update me or update us on the PARP PD-1 combo trial? So there's an HRD biliary tract specific trial, or is it all comers?
There is one that's include biliary cancer. These trials are all like tentacle basket trials, and they include biliary tract cancer cohort.
Are there any signals early on?
So there are signals in other cancers that this could be viable. The problem, again, it's too early and it's very difficult to understand. So do you do it just in HRD positive? Do you do it in BRCA mutated? Do you just do it in everyone? And that's one of the challenges of how these are being developed right now as it is.
Yeah, I mean, at the genomic level, there are signatures that look very strikingly different. But you're right, if you ignore the genome, which is
Yeah.
a complicated mess, at the clinical level,
Yeah.
there's a continuum.
Absolutely.
You're right, and I don't think we know where the line is. Yes? Maybe over there, sorry.
Great, sure,
Yeah.
thank you. This has been great. So I want to just sort of state my understanding of kind of what you shared for the benefit of me and other patients. I'm a caregiver, but my wife, or as my wife points out, she also gives a lot of care too. But what you're talking about here, just in terms of the broad scheme, is that there's this deficiency in repair that is the HRD group, right? And because a lot of folks who are patients know they have these mutations, and they get their foundation report, and it might say MLH1, or it might say BRCA2, or it might say POL. Are those mutations sort of all in the family of HRD, like that deficiency, or is that itself another sort of listing that would appear on a report?
So that would not appear as a listing on the report because, this continues to be a moving target except for few. So there is nothing called HRD on any report. So you get your foundation medicine report, you look at it, nothing's going to tell you it's HRD. So it's actually a bunch of repair protein genes and proteins working essentially collaboratively to repair the DNA. And so the mutation can be, remember there were 6 repair pathways at least, and each pathway is taken care of by, some genes, and some are caretaker, others are essentially direct repair genes. And so this is much more complex. The whole concept of HRD is much more complex than just, identification of a single gene. So when you get the report, actually, when you go into the last few pages of the report and you have a listing of 100 different genes they call them VUSs of unknown significance, many of them may end up becoming significant with time as we learn them. So at this point of time, the only ones we know that matter are BRCA1, BRCA2, PALB2, possibly Pol E and Pol D for other purposes. And then the others that we're learning about are ATM, ATR, and we want to understand how they fit into the picture. And then all the others that we listed we don't know much about other than they belong to that family and they may be relevant. So clinically, that's one of the challenges of looking at these and making sense out of them.
There are HRD-specific assays that are used in other cancer types. One well-known one is the MyScore panel made by Myriad Genetics. But again, those are used more in other cancer types and not clinically pertinent at this time in cholangio.
It hasn't been validated outside ovarian, so, and even the Myriad one is kind of limited, right? It's like I'm saying, it's a moving target. So clinically, what's applicable today is really limited to the ones we know really have that drive and we can actually hit them. The others, we don't know. We need to continue exploring.
Yes. Yes, over there.
Hi, my name is Lori Wartsma, and I'd like to reintroduce myself to you, Dr. Saab. You were my doctor for about 8 months, summer of 16. I was a patient at the Mayo, and I think I have a simple request. Due to the fact that a lot of the slides, we couldn't see the real guts of it, I was wondering if we could get a copy, or I could get a copy of it to share with my current doctor.
The slides? Absolutely. They can be made available by the CCF folks, absolutely.
Okay, so they'll have them and,
Yeah, there's
Speak to
nothing in
somebody?
there. Yeah,
okay. I'd like to share them with my current doctor.
absolutely.
Thank you.
Of course.
Thank you. I think last question. Is that right?
Okay. So I have an interest in the list that you put up of the direct repair genes, and you've talked about that some. One of those was MLH1, and of the people that I know across the world who have tried checkpoint inhibitors, Keytruda in particular, primarily everyone who has had success has had the MLH1 mutation. the list is much bigger than that. Your list is bigger than that, and my question is there, do we know, do other mutations, the BRCA mutations, are they potentially going to respond in the same way to checkpoint inhibitors, or we don't know, or we know that they don't, and why would that be? Kind of lumping them all together. I've posted that information out in some groups already, and so people are asking, oh, you know, my husband has the BRCA mutation. Does that mean that that Keytruda might work for him too?
Yeah, so, you know, the simple answer to this is, remember the analogy I made about the wall. The wall, and if you, the PD-1s, what they do is they reach the brakes, and those cells just rush, or try to rush into the cancer cell. The problem, you have these bad cells that are there that really prohibit those cells to go in. So regardless of whether you have the BRCA mutation or not, these PD-1 inhibitors, unless you have the elements that suppress the bad cells, the MDSCs, the Tregs, so T cell regs, you're not going to be able to hit your target. So it's not a question of whether the tumor is able to get to get a response from the PD-1 inhibitors or others. It's a question of whether you can get to it or not. Now, if you can get to it, then you can do that. And part of trying to get to it will depend on multiple factors, including one, as I discussed. You know, that's why, you know, the thought is to start thinking about combining these PARP inhibitors with PD-1 inhibitors. So in these BRCA mutated tumors, what these PARP inhibitors would do, in addition to essentially make the cancer more visible, the cancer cells more immunogenic, and the milieu, which is more important, they essentially bring down the level of these bad cells, these MDSCs and these Tregs. So that wall comes down. Now you give your PD-1, and then you're going to hit the tumor. So it's more complex than just, you know, the fact that they may be more immunogenic doesn't mean that they're visible to the immune system.
Do you know if there's any trials related to that?
There are a lot of trials that are ongoing right now with PD-1 plus PARP inhibitors across the U.S., Canada, I'm sure, maybe a couple.
My only point to add to that would be to be wary of that MLH1 mutation. It could be a passenger mutation.
Rather than a driver.
And there isn't a high enough mutational burden in most of these tumors, which is where the immunotherapies sort of have their major benefit. Anyhow, I think we'll close it out. Terrific.
Thank you.
An exciting series of talks. Thank you. Thanks.